Hello, my name is Dr. Indrani Biswas, and I will be presenting on multiple sclerosis. Multiple sclerosis, as we all know, is a chronic autoimmune demyelinating disease of the central nervous system, which is characterized by demyelination, neurodegeneration, and inflammation, as a result of which the immune system attacks the myelin sheath, disrupting the nerve signal conduction. And over time, there's axonal damage and oligodendrocyte loss as well. The common symptoms of multiple sclerosis includes fatigue, loss of balance and dizziness, speech problems like dysarthria, stiffness and muscle spasms, tremor, numbness and tingling, and other peripheral neuropathy like symptoms, and optic neuritis, which includes pain on eye movement, blurred vision, poor contrast or color vision, and at times there can be internuclear ophthalmoplegia also. In addition to it, spinal cord can also be affected, leading to bladder problems. So, what are the types of multiple sclerosis? There are four types. The most common is relapsing remitting multiple sclerosis, which is seen in about 85% of cases at initial diagnosis. The second most common is the primary progressive multiple sclerosis, which is seen in around 10 to 15% of cases. The next common is the secondary progressive MS, which develops in many benign RRMS patients over time. And the least common is the progressive relapsing MS, which is now often classified under PPMS. So, what does primary progressive multiple sclerosis mean? Do you have any idea about what it is? So, it is a distinct form of multiple sclerosis which is characterized by a steady and gradual decline in neurological function from disease onset without any relapses or remissions. The spinal cord is the most commonly affected in PPMS, with predominant symptoms like spastic paraparesis, imbalance, as well as urinary urgency and episodic constipation. There is less inflammatory activity seen on MRI, with fewer gadolinium enhancing lesions on the MRI as compared to the RRMS patients, and it is characterized by a slow, irreversible progression of disability. So, according to the 2017 McDonald's diagnostic criteria for PPMS, the diagnosis requires at least 1 year of disease progression, which can be either prospectively or retrospectively determined, and two of either dissemination in space findings in the brain, where there is at least one T2 hyperintense lesion in the either the periventricular, the juxtacortical, or the infratentorial regions, dissemination in space in the spinal cord, where there is at least two T2 hyperintense lesions in the spinal cord, or CSF specific oligoclonal bands, where there is evidence of intrathecal IgG production in the absence of infection. So, there is no specific laboratory markers for MS, but usually we see low vitamin D levels in MS patients. And to rule out other causes, we also check for the thyroid antibodies. To rule out infectious causes, we check for the antinuclear antibody, the sedimentation rate, the CRP, and also other autoimmune diseases like NMO, like neuromyelitis optica, or the MOGAD disease. We check the aquaporin 4 antibody and the myelin oligodendrocyte antibody. The most exclusive finding seen in CSF in MS are the oligoclonal bands, which indicates the intrathecal synthesis of IgG, mostly in the CSF. And it can be detected by isoelectric focusing, followed by either immunofixation or immunoblotting. Also in the CSF, we find some other characteristics like mild pleocytosis with WBC count of less than 50 cells per microliter, mostly lymphocytes, and a normal or slightly elevated protein level of less than 100 milligram per DL. As well as we can also see the elevated IgG index in the CSF. So these are the patterns of oligoclonal bands. So how to find the oligoclonal bands by laboratory assay? So we collect the serum and the CSF samples, and we go for assessing the CSF quantification as well as the IgG total protein, followed by which we go for the isoelectric focusing, which helps in separation of the proteins based on the isoelectric charge, where the pH has no net charge, followed by which electric focus is applied and the immunoglobulins migrate and focus into bands where the pH is net zero charge, followed by which we go for the specific testing, which is the immunoblotting or the immunofixation test, where after separation of the proteins, the gel is treated with anti-human labeled RBC antibody with a marker like a fluorescence marker, which helps in good revelation of the distinct bands. So in MS, there are more than 2 bands in the CSF. As we can see here, this is known as the type 2 pattern or the CSF restricted pattern, where we see the intrathecal synthesis of IgG exclusively in the CSF, and it is seen most predominantly in MS patients. The type 1 pattern, as you can see here, is the normal pattern where we don't find any bands, and it is seen in normal patients. The type 3 pattern is known as the CSF restricted with additional bands in the CSF, which can be seen in MS as well as in other autoimmune and inflammatory diseases. The type 4 pattern is the mirror pattern, as you can see here, where there are same set of OCBs both in the CSF as well as in the serum, and it indicates blood-brain barrier disruption and leakage of the proteins into the CNS, and it can be seen in other infectious and inflammatory conditions as well. And the last but not the least pattern is the monoclonal protein pattern, where there is presence of dense M bands, and it is suggestive of either monoclonal gammopathy of undetermined significance, or it can be suggestive of multiple myeloma. So do you know any other conditions where we can see oligoclonal bands apart from multiple sclerosis? So we can also see oligoclonal bands even in neurosyphilis, neurosarcoidosis, autoimmune encephalitis, and other conditions as well, although it's not as specific in these conditions as it is in multiple sclerosis. So in epidemiology of PPMS shows that PPMS is more common in the Scandinavia as well as in Northern European regions, and it typically presents in 40 to 50 years of age, and it has a slight male predominance as compared to the female predominance seen in relapsing remitting MS, with an age of onset in RRMS being 20 to 30 years of age. Also, in PPMS, we can see greater spinal cord involvement and fewer brain lesions, as I said in my previous slide earlier. So as you can see, the pathophysiology of PPMS involves chronic neurodegeneration followed by spinal cord predominance with diffuse axonal injury and meningeal inflammation. So this is the microscopic diagram of patients with MS, where the myelin is normally stained black with myelin stain, and when the patient is affected by MS, there is reactive astrocyte proliferation leading to gliosis or scarring. And this is the typical plaque or focal area of demyelination, which does not take the black stain as compared to the normal black stain we see here. And there is also absent oligodendroglial cells in this plaque. And the axons are visualized here, but they are not as prominent as it is here. So the pathogenesis of MS involves the presence of autoreactive cells in the immune repertoire, where they encounter their structurally related antigen as well as major histocompatibility complex, which is presented by the antigen-presenting cells or the dendritic cells. Once the T cells get activated, they release a bunch of cytokines, chemokines, as well as matrix metalloproteinases, which initiates an inflammatory reaction, and it causes the more axonal demyelination as well as oligodendrocyte damage after the cells get reactivated in situ by a local antigen, which is displayed either on the microglia, the perivascular dendritic cells, or the pericytes. And they adhere to the adhesion molecules and they enter the endothelial lining of the vasculature, and ultimately they invade the CNS. And on the other side, the B cells infiltrate this perivascular cuff adjacent to this inflammatory focus, releasing antibodies, causing complement-mediated opsonization and assembly of the terminal lytic complex component protein C5b to C9, leading to further axonal damage and demyelination. So I had encountered a patient in the clinic who was a 65-year-old male with the diagnosis of primary progressive multiple sclerosis diagnosed 20 years back. He presented in a wheelchair, unable to ambulate, with lower limb spasticity, more predominant on the left, and there was asymmetric weakness on my neurological findings with vertical predominant nystagmus and bilateral spontaneous Babinski sign, which was very classic. Also, there was some pseudobulbar effect with occasional crying and inappropriate laughter. And also, there was urinary incontinence and episodic constipation, but with preserved bowel control. So, do you know what the plan of approach was for this patient? What he was treated with? So he was treated with a combination of Tecfidera 120 milligram BID, which he well tolerated, as well as Seroquel for the psychiatric support, Nudexta, which is the dextromethorphan hydrobromide for the pseudobulbar effect. And he was also provided some educational materials like Ocrevus or Zeposia. And his wife was also very involved in taking care of him and providing with any useful findings she would get during their day-to-day care. So this is the neurological examination summary that I had briefly explained to you. So as you can see here, this is the axial T2 weighted image showing the focal hyperintense lesion in the juxtacortical white matter. And this is the FLAIR image. These are again FLAIR images showing the characteristic hyperintense lesion in the deep white matter and in the periventricular regions. And these are again the same kind of findings with the dorsal fingers, the typical hyperintense lesions. So this is the cervical spinal cord level, which shows hyperintense focal lesions at the C1, C3, C4, and C5 levels with gadolinium enhancing lesion in the T1 weighted image. These are again a couple of images showing the typical hyperintense lesions on the cervical spinal cord as well as in the brain and in the brachium pontis region. So the FDA-approved disease-modifying agents for the treatment of MS involves interferon beta-1a, beta-1b, glatiramer acetate, metoxantron, natalizumab, although it has an adverse effect of causing progressive multifocal leukoencephalopathy, and fingolimod. And the newer drugs which are in development includes the anti-inflammatory small synthetic molecule laquinimod, the immune modulator, which is either dimethyl fumarate or teriflunomide, the CD25 monoclonal antibody, which is the daclizumab, the alemtuzumab, which is the CD52 antibody. As we all know, rituximab is the CD20 antibody, and the Ocrevus or the ocrelizumab, which I was talking about, which was given to the patient, is CD20 monoclonal antibody. So Ocrevus or ocrelizumab is indicated in PPMS and RRMS patients, and the mechanism of action involves antibody-mediated cellular cytolysis and complement-mediated lysis, given mostly by IV infusion, whereas Zeposia or ozanimod is a newer form of drug, which is a sphingosine 1 phosphate receptor modulator, which is given in oral formulations. So as I was talking, Zeposia acts on the S1P1 and the S1P5 receptor, where at the 1 receptor, Zeposia causes regulation of the migration of lymphocytes and other immune cells, where it acts as a gatekeeper, and at the receptor 5, it also plays a role in the life cycle of oligodendrocytes in the CNS. So as I was saying, Zeposia acts as a gatekeeper by keeping immune cells from moving out of the lymph nodes and into the CNS, which may prevent damage to the CNS. So other ancillary mechanisms by which the patient can be treated would be symptom-targeted therapy for spasticity, which can be either treated by baclofen or tizanidine, pain, bowel and bladder issues, which can be treated by oxybutynin and other muscarinic antagonists, and emotional regulation, which was treated with Seroquel and Nuedexta. Rehabilitation services, including physical, occupational, and speech therapy, was also provided to the patient, along with psychosocial support to improve the quality of life. So the differential diagnosis or rule out mimics for multiple sclerosis includes vitamin B12 deficiency. As I said, the second is the neuromyelitis optica spectrum disorder. The third DD is hereditary spastic paraplegia, which causes spasticity and weakness in the lower extremities. The fourth includes infectious myelopathies like HIV, HTLV1, which causes tropical spastic paraparesis with the classic scissor-like gait, syphilis, or the Lyme disease, which can also cause the peripheral neuropathy by the tick Borrelia burgdorferi, structural spinal cord lesions like cervical spondylotic myelopathy or tumors, and the last differential diagnosis includes other metabolic and vascular myelopathies like spinal cord infarction, copper deficiency, or folate deficiency. So the prognosis and long-term outlook in PPMS patients includes a gradual worsening of the neurologic function with a median time to cane dependence of 7 to 10 years from disease onset. And the wheelchair use becomes almost mandatory within 15 to 20 years in many cases. Male sex is always associated with a poorer prognosis as well. So early initiation of disease-modifying therapy with Ocrevus or Zeposia may help in slowly reducing the rate of progression, and also other lifestyle modifications and symptom control, improving the quality of life and as well as mental health. So I had encountered another patient who was diagnosed with benign MS in 2022, who presented initially with numbness and tingling in the feet, with balance issues and frequent falls, including slurred speech. So she was diagnosed with benign MS after spinal tap revealed around 8 times the oligoclonal bands with a high IgG index. So even if she was offered the conventional medication, she declined it and she opted instead for natural remedies like oral alpha lipoic acid, sublingual vitamin B12, and liquid vitamin D. So, what do you think would have happened to the patient in the next 3 years after she was diagnosed in 2022? Did she improve? Was it stable or did she deteriorate? So, her current status in 2025 showed persistent symptom only, including numbness and tingling in the bottom of the feet, whereas other symptoms had resolved, like the speech problem, as well as the gait disturbances and the frequent falls. So it showed that natural remedies could also have some effect on the MS symptoms as well. So this is the comparison showing the difference between the primary progressive MS and benign MS, with a gradual progression in primary progressive MS with instability and also disability and need for assistive devices, as compared to benign MS, which is more has more periods of stability and it doesn't lead to significant disability as well. So these are the common localization signs of MS relapse, where we see the characteristic Lermite sign, where the patient presents with electric shock-like sensation when he or she flexes his neck, which indicates dorsal upper cervical cord involvement, diplopia or vertigo, which indicates either the cerebellar pathways or the medial longitudinal fasciculus, and as we all know, subacute hemiparesis, which involves the corticospinal tract, or the ascending numbness, which involves the lateral and the dorsal funiculi of the spinal cord. And these are the references that I used to include it in my presentation. Thank you so much. You can ask me any questions if you have any. Thank you.